So a warm welcome to everybody to joining our call to today's iCMLf Meet-the-Expert CML session. This session will be dedicated to TKI toxicities and dose optimization in CML, and we are very much looking forward to a very interactive Q&A session with you today. So again, please welcome to today's Meet-the-CML-Expert Q&A session on TKI toxicities and dose optimization. We decided to run another Meet-the-Expert session this year because the session last year was very interactive and received lots of questions from you. So we decided to run another questions, but this time dedicated to two very important questions to your clinical practice. So it's my privilege to introduce our two experts today. Please welcome, a warm welcome to Professor Jeff Lipton from the University of Toronto and Professor Timothy Hughes from Adelaide in Australia. For those who are expecting genitourinary today, unfortunately he is unable to join due to personal circumstances related to the flood, the recent flood in Italy. So we're very happy to have Professor Timothy Hughes to replace Gian Antonio today. Thank you so much. So now I'd like to introduce Professor Jeff Lipton to you. He is Professor of Medicine at the University of Toronto and serves as clinician investigator at the Cancer Clinical Research Unit at the Princess Margaret Cancer Centre at the University Network in Toronto. And he has a long expertise in clinical research in TKIs, as well as outcome analysis in stem cell transplant and the prevention and therapy of side effects, so one topic that we will be discussing today. He is on several international advisory boards relating to the therapy of CML, including the ELN recommendations and the Canadian CML Guidelines Committee. Please welcome, Jeff. Thank you so much for being here today and for sharing your expertise. So, the majority of you may be familiar with Timothy Hughes, our chairman, the chairman of the foundation. He is a precision medicine theme leader at SAHMRI in Adelaide, beat cancer professor at the University of Adelaide, and he is also consultant hematologist at the Royal Adelaide Hospital in Australia. He has a long-term commitment to developing better therapies for CML with a major focus on maximizing the opportunity for treatment-free remission. Be welcome, Professor Hughes, and thank you so much for jumping in at last minute. So in terms of the program, we've got approximately 40 minutes for Q&As today, and we'd love to go bit by bit today, starting with your questions on managing safety toxicities and safety issues. Then another section on questions that are more related to dose optimization. And at the end of the questions, we have a couple of specific questions from you that we'd like to discuss with both of you. So let's get started. The first questions we received prior to the meeting is about how do patients with ulcer manage the toxicities of TKIs? There's one quote from, I assume, a question saying that it's really hard, a big topic for at least some of the patients. And ulcer seems to worsen during TKI therapy. And the question to you is, what is your advice here, managing ulcer with
I think it's
TKI?
a very difficult question. And obviously,
would you like to start?
It's a difficult question, obviously a difference from patient to patient. I think a lot of the reason patients with ulcers have problems with TKIs is I think there's this warning that comes with TKIs about not using proton pump inhibitors and not using H2 blockers. So that may actually trigger or worsen ulcers which require treatment. I think the first thing is, personally, I would estimate, at least where I live, a quarter of patients are on something for acid blockade, one of the two. And I actually do not stop those drugs. And I've really not found evidence of any significant toxicity. My general goal with individuals is if you're on a PPI and necessary to control your ulcer, I have them take their TKI and then take the PPI a couple of hours later. You have to be very careful what ulcer medications you're using. So things like Sulcrate may actually block the absorption of some of the drugs. So you have to avoid things like that. The other thing is, how do you take it? With the exception of nilotinib, most of the TKIs can be taken with food or right at the end of a meal. In fact, it's encouraged to do so. If you're trying to take a TKI other than nilotinib on an empty stomach, then I would suggest maybe trying to take it right at the end of the meal when your stomach is full and it's very much protected from some of the side effects. The other thing, of course, is if you have ulcers that are not controlled, even with medication, worsen with a TKI, maybe there's more going on than an ulcer, and perhaps something like that should be investigated for something a little worse. So generally, I think the big thing out there is this black box warning with all of them. Don't take with H2 blockers, don't take with PPIs. I don't think that's necessarily the case that has to be dealt with.
Great, thank you so much. Anything to add, Tim? Please jump in.
Sure. No, I think I agree with Jeff.
Great. So the second question we received is, what can you say about the phosphate levels and bone health in patients treated with TKIs? Tim, can you take this question?
Yeah, we do see some patients with lower phosphate levels, and it's kind of complicated to know what the cause is. We'd also see patients with elevated parathyroid hormone in some cases. So occasionally you do get levels that are so low that they do concern you, and occasionally I've used oral phosphate supplements, but generally you see mild phosphate reduction, typically with imatinib, and I don't think it has huge significance for the patient. I think in terms of bone, there's been a lot of concern, obviously leaving aside the question about retarded growth in adolescents. That's a significant issue, I haven't got huge expertise in that, but it's a big concern. But in terms of adults and bone disease, we're very worried when we first used these drugs because they do seem to inhibit osteoclast activity, and we thought that we'd have very almost stagnant bones, not enough turnover happening. You might have brittle bones, but we don't really see a lot of problems with bony disease in patients on long-term TKIs. We're not seeing increased risk of hip fractures, etc., bony fragility. So that's probably something we focused on 20 years ago when we were first using imatinib, and we haven't really sort of focused on it much since then because it hasn't really seemed to be a clinical problem.
Okay, great. Then there are a couple of questions specific to certain TKIs. This question is on imatinib. What are the long-term renal effects from imatinib, even at low doses of less than 400 milligrams? That's a question.
Well, that's been an effect that's been noticed with imatinib for a couple of decades now. I think people have to remember two things. There are two renal effects with imatinib. There's the chronic effect, which is slowly worsening creatinine, which can occur in individuals. And that's particularly more noted in individuals who have other reasons for renal. So diabetics, people with hypertension, things like that. So it tends to complicate things. But even individuals without those, there's this tendency for creatinine to get worse. There's also something which a lot of people don't know about, and that's the acute renal toxicity of imatinib. And this was something that was discovered maybe a decade ago by our French colleagues. And that shows that imatinib actually blocks the secretion of creatinine. And it's an acute effect. And if you stop the imatinib within 2 or 3 days, if that's the effect, the creatinine will normalize. So the first thing I would do is make sure it's not just that effect, because that seems to be relatively benign. The second thing I would then make sure is that if you controlled all the other potential problems with renal dysfunction that can occur, optimize the diabetes control, things of that nature. If completely necessary, you may dose reduce, and I'm a big believer, we'll get into this a little later about dose changes with drugs. I believe in reducing doses of all drugs to the maximum efficacy, minimum toxicity level. So you may want to reduce it, but it doesn't necessarily, as pointed out, reduce the effects long-term of imatinib. It may be necessary in some cases even to consider a switch to another medication. I think it's most important if it's really profoundly getting worse to the point where intervention is necessary from the renal point of view. I think good nephrology involvement at that point is profoundly necessary.
Anything to add?
Yeah, it's probably the only really serious long-term toxicity probably that I can think of imatinib. It's the sort of steadily worsening renal function, which you see in quite a lot of patients. And I certainly have changed some patients, but it depends on what their other risk factors is where you want to change to. I guess today I would think about changing to reduced dose dasatinib, maybe 50 milligrams dasatinib, in a patient who was doing very well. And I was worried about progressive renal impairment, because I don't think we see that with dasatinib. Jeff, that be your experience as well?
The only thing you do see with dasatinib is, if you look carefully, a percentage of individuals will develop proteinuria on dasatinib, which is reversible within a few days of stopping the dasatinib. So it can be nephrotic range proteinuria, 3 grams or something like that, but it is reversible and it seems to be relatively benign. Otherwise, I've not seen side effects.
Yeah.
But you do see side effects in CML patients. Remember, the median age in the Western world is 65. They have diabetes, they have high blood pressure, they may have other things that affect their kidney function as well.
Yeah.
So it's not necessarily related to the TKI.
No, but it does seem to be more related to imatinib than the other TKIs. So that's the rationale, perhaps switching. Yeah.
See, there are live questions coming in. There's one question from the list we received. Did you see severe iron deficiency in patients treated with imatinib? Question to you, Tim.
Right. Well, you do see iron deficiency because it's a common thing in the community, and you've got to think about the usual causes of iron deficiency. But you can get a sort of a chronic gastritis with imatinib, and you also get this nasty thing that Jeff's reported on, and so have we, of gastric antral vascular ectasia, or GAVE. It's pretty rare, but if you see it, the ones that I've seen haven't presented with iron deficiency, or that's possible. They're presented with quite frank, vomiting blood, and it's been recognised, and it can be quite alarming. It can be described as a watermelon look to the stomach, and if the imatinib is stopped and switched to a different drug, it tends to go away, in my experience. So it's something to think about, and fortunately, I think it's something like 1 or 2% get that. But I think you've certainly reported it, haven't you, Jeff? You've got a couple of cases in your that you've discovered. I think you might have been the first person to report it, actually.
Well, the first person in CML. There were reports.
There's a GIST report.
With GIST. I think one of the things to remember is, when you're a CML patient, all of a sudden you're being monitored a lot more closely than you were before you were a CML patient. You may be having blood work done for the first time routinely, where you may never have had a CBC or something beforehand. Iron deficiency is not that uncommon in the population. In younger women, related to menstrual history, and older people, you really need to be investigated for gastrointestinal malignancies. So I think maybe it's being picked up more because you're on and being monitored. So I think that's something that has to be thought about. I think it needs to be dealt with, as Tim mentioned. You need to work it up. It's not necessarily due to the drug, but if you're of the appropriate age, you need to be scoped. If you're
absolutely
a female who's got heavy menstrual periods, then you need to be supplemented. But don't necessarily ascribe it to the imatinib. It just may be that it's being picked up because you're being monitored.
Exactly. Very important.
Great. Thank you so much. There are 2 new questions coming in via the chat. The first question is related to cytopenia. Says there are patients who are unable to tolerate TKIs, even with doses, reduced doses and different TKIs used. Can you any one of you refer on this question?
I'm willing to start it. So, cytopenias overall are not that common. They're maybe very common in the first few weeks of starting a TKI. And that is because at the time of diagnosis, a lot of your blood cell production comes from CML stem cells, and they get shut down very efficiently by all the TKIs, but that will rebound with normal clones, and it doesn't occur. There are a few percentage of people who switching TKIs won't help here. It's just that for some reason, the normal blood cell production has been shut down, and the only clones producing blood cells are CML clones. And any TKI you put them on shuts it down and shuts down blood cell production. I think if you've got recurrent episodes of that over a period of time, that concerns me, because these are individuals I worry about that not getting sustained use of a TKI may bring on advancement or acceleration of the disease. And in all honesty, I see 1 of those 2 patients a year And I think if they are eligible and have the donor, those are the people I will take to a transplant.
Yeah, I think it's one of the most difficult situations we face in the chronic phase management scenario. It's patients who are cytopenic. It's not so bad if they're cytopenic and they're responsive and you can sort of stop and start and they maintain response. But the patients you're really concerned about are the ones who maintain high levels of BCR-ABL positivity, but they develop severe cytopenia. And all I would say is that we tend to be more aggressive in continuing therapy, even in the presence of cytopenia, particularly in the first 3 to 6 months of therapy, because if you don't, and if you have lots of interruptions, you can really get into trouble quite quickly. So, of course, there's a risk involved in continuing therapy if a patient's got 30,000 platelets, but we tend to take that risk. We tend to use GCSF very sparingly, but to allow us to continue to give people a drug and keep their neutrals above 0.5. If we can keep the neutrals above 0.5, even with intermittent GCSF, we'd rather do that than stop and start, because that seems to be a recipe for trouble. But I can't give you any objective evidence that that's the best approach, but it's a really difficult, and as Jeff says, an uncommon problem. I'll be interested to know how Jeff feels about that. Have you ever had to use GCSF? Or are you reluctant to do that? I know we've done it quite a lot in Australia, and it's hard to be sure because these are high-risk patients, but it seems to be an effective way of maintaining therapy.
Rarely, actually. In 1 or 2 patients I've tried it on, though in fact in those cases it has not worked terribly, and I'm very antsy about the on-off event. And as I said, those are the 1 or 2 patients a year that I may take to an allograft.
Yeah, well, that's the other thing to say, is that these are patients that will often end up having a transplant because you cannot get enough consistent dose to get any response. It may not just be the interruptions, it may be something underlying about their disease, which is just prevents recovery of normal hematopoiesis.
Okay, yeah, great. Thank you so much for sharing your experience from your practice.
So the other important thing that Jeff did mention is that it doesn't help switching from one to the other and back again, because they all do it, and including asciminib. So that is not a sort of a nice, easy answer, unfortunately.
Yeah, it's not specifically drug related. It's just there's only clonal blood cell production, and they're all great at shutting down that flow.
Thank you so much. There's another question that has just come through the chat that's related to diabetes. We've been talking about like managing diabetes. The question is, I'm wondering if a person can become pre-diabetic while taking TKIs, especially under bosutinib. Can the diagnosis be linked to TKIs, or if there is any family history, if this is more likely to be the cause? Okay,
I'll start with that one. So, I mean, nilotinib is quite notorious for pushing people who are not at all diabetic into a pre-diabetic phase, and even patients who are pre-diabetic into a diabetic phase. And it's not uncommon. And one of the big worries that we had with the initial nilotinib studies. So there's no question that if you've got pre-diabetes and you don't want to push that into diabetes, nilotinib is not a great drug. And maybe we used it sometimes in the past because we didn't have a huge number of choices. But these days, with better understanding about how to use dasatinib safely, with the availability of asciminib in many countries, I wouldn't tend to use nilotinib as a preferred drug in a patient who was diabetic or even pre-diabetic for that very reason. I think, fortunately, imatinib has the opposite effect. It seems to actually improve diabetes, and you actually can get into trouble sometimes when you stop the imatinib. That can then, in effect, make the diabetes look worse. So I would very much prefer imatinib in a patient like that, as long as the other indicators were in favor of that, rather than nilotinib. I think dasatinib, as far as I know, was probably neutral, but that's probably my how I look at it.
I think the other drugs are neutral. Nilotinib is the one that used to trigger it. It's one of the things we worried about when we were first doing the nilotinib studies, we would see it. I think this all goes back to when you see a patient the first time. You may be a hematologist or somebody seeing them, but you need a good medical history, because you need to know what other potential comorbidities they have, both now and what they may have from a family history. I think a lot of people are actually seeing pre-diabetes. Again, the same reason we're seeing some of the other things like iron deficiency is people are getting monitored. So people who would normally not have symptoms, not go for an annual blood test where they would look at a blood sugar or something like that, are getting monitored for things which include blood sugars, and suddenly it's being seen. So I think it's being picked up more because people are being monitored. Well, I agree with Tim, with the exception of imatinib, I don't think most of the drugs trigger it. But again, in the Western world, we're dealing with a population in the 60s where type 2 diabetes or borderline is not uncommon.
Quite common.
Mm-hmm. Great, thank you. There are more and more questions coming, and we've got a long list. So I'd love to take...
Sorry, Stefanie, just to remind everyone that we can't answer specific cases about patients' challenges. We're talking general principles here. We can't really deal with specific cases.
Yeah, thank you for pointing out. And as usual, we won't be able to answer all the questions, but we definitely keep those questions, and we may find a solution, and at least we take over these questions until the next Meet-the-Expert session. So nothing will be lost, but we won't have time for all these questions. So I'd like to take one of the questions that are more related to managing toxicities. There are a couple of more specific. One question is, it appears that each TKI drug has toxicity built over time. Given that, would it be prudent to have patients change TKIs drugs every few years to avoid the buildup of specific toxicities, essentially trading around the toxicities to minimize overall impact? That's a more general question.
That's a great question. I don't think most of us had appreciation for the long-term toxicity of these drugs. I was fortunate to be able to author a review of that, which was published about a year ago, where we looked at the long-term toxicities. Most of what we think about toxicities comes from the studies and what's in the product monograph, but we went beyond that and published a very extensive, boring review because it's nothing but tables, but if you want to know something, it's there. Yes, there's a lot of things pop up long-term. The question is, can you avoid those by switching drugs? Well, I'm not sure that anybody knows that for sure. I think I'm concerned, though, about switching drugs. Because and this was unfortunately, it went on for a while, particularly in the United States, is people would use drugs in rotation just to see which one they liked the best. I'm concerned that you may lose efficacy or develop new toxicity. We have done studies in the past of attempting to switch drugs in order to get better responses, and individuals who were totally stable with no issues suddenly got all sorts of new and sometimes very severe toxicities. I don't think it's a great idea. I think people need to be monitored for the approaching possibility of these things and consider at that point an appropriate management. If that is a change of drug, fine. Just a random moving around in drugs, I would not think that's such a great idea. I don't know what Tim thinks.
Tim,
yeah,
do you agree?
Well, I mean, I agree in principle. I mean, I think there's a lot of different views on this. I know that a lot of my colleagues are very strongly of the view that once you're on a drug, stick to it because you don't know what's around the corner if you change. And to some extent, there's some truth in that. I certainly know that patients who are unhappy, very quickly with a drug, and we switch to another drug, you often end up going round and round in circles. That's a problem. But having said that, I don't think you should slavishly stick with a drug if there really are problematic side effects that are, having impact on quality of life. I think it's worthwhile, given the fact we do have, quite a few drugs now and different ways of using them in different doses. I think we should try and find the drug that agrees with that patient best, and that can sometimes take a bit of trial and error. And I'm not uncomfortable with that process. I guess in Australia, we're allowed to change from drug to drug to drug based on toxicity issues, not based on resistance issues. So we tend to do that until we find the drug that suits that patient best. And I think that's okay. But there is always that danger that some patients, you'll create that situation where they keep trying to find that perfect drug and there's no perfect drug.
I think Tim and I are saying the same thing. I think Tim is talking about the fact that you've got a patient with problems related to drug that switch. And the question was related to prophylactic changes to prevent coming. I agree
That's a good
totally with
point.
Tim, is finding the right drug that fits a patient in terms of toxicity and quality of life issues is really important. Changing
Yeah.
randomly on the thought that it might prevent problems is something, and there's no evidence about that, I think, at all.
Yeah, Jeff, probably the only situation where I now am thinking about doing that is the patient on long-term nilotinib.
Exactly.
I mean, I think patients who are on beyond 5 years of nilotinib, the data from NSND, while it was pretty reassuring in the first 5 years for patients who were low foraminum risk, even those patients started to get cardiovascular events in the second 5 years. So if I see a patient now who's had more than 5 years of nilotinib and they're not on the brink of attempting a treatment-free remission, I'm thinking then about changing them. For a while, I was actually halving their dose based on the observation that 400 twice daily is clearly more toxic than 300 twice daily. I'm hoping that maybe 300 once a day, or 150 twice a day, 150 once a day would be better. But even more so, I'm going to half dose dasatinib. And more recently, because I can, I'm starting to look at asciminib as well. So I think this is an area where, the patient's perfectly comfortable in their drug, but I am getting concerned about that cumulative toxicity. And it sounds like you've got a similar
I get
concern.
my same feeling with nilotinib, but the majority of cases I haven't necessarily switched. I've had some kids have gone back to imatinib if they started nilotinib front line. In other cases, I have many of my patients now on 300 milligrams once a day, and I'm watching them carefully, and I'm very aggressive about managing cofactors. Dasatinib 50, I think, should be the standard right now. I think there's good research that came out of France, which shows that blood levels that are effective can be obtained with 50 milligrams of dasatinib a day. We don't need 100. So I have a new dasatinib patient, unless I've got a highly resistant patient, I'm switching to dasatinib. I'm starting at 50.
Yeah, agree. Our most recent study in Australia was
anymore. I think that is should be the dose.
Okay, great.
We do exactly the same. There's a lot of enthusiasm for 50 milligrams of dasatinib for reasons I don't fully understand. It seems to be probably because patients take it every day rather than interrupting because of toxicity. You get remarkably good responses. So
and
we agree again, Jeff.
Fewer as well.
Thank you both. So we're right into discussing strategies for dose optimization. There's one final question I'd like to take on before we move on to more dose optimization questions. Any recent studies regarding pediatric CML and how toxicity from TKIs can be monitored and administered? Can any of you point this out?
Well, I read the papers, but I don't look after any children with CML. So I'm a bit reluctant to put myself up as an expert in that area. We probably should have a section on that where we actually get some of the pediatricians who have huge experience. I don't know. Do you treat children at all, Jeff?
No. I may have an occasional 17-year-old. That's the youngest.
Yeah, it's about my limit as well. So I'm a bit reluctant to sort of, offer opinion, which is based on, because I read the papers, but I don't have specific expertise.
It's a really uncommon disease in kids. Remember, in the Western world, the median age is 65, and in Asia and Africa, it's maybe around 40 or so. So that's still very uncommon in that age group. So I think the most important thing about that is you need an expert in pediatric CML to manage that. This is not, I think, something that can be managed.
You can dabble in.
Great. And just as an information from our audience, we usually collect papers on pediatric CML as part of our monthly publication notice. So it would be worth checking our website. There is a pediatric CML dedicated session, and there are lots of recent papers, so it might be worth checking this. And I'd like to, if you agree, I'd like to move on to more questions on dose optimization. We've received a couple of general questions. The first is, do you already start with doses lower than scheduled? If yes, on which occasions? And if yes, with all TKIs or with what TKIs? Tim,
Jeff,
would you like to start?
Do you want me to start?
Okay. So with dasatinib, I think Jeff and I have already mentioned the fact that the data is really building up. We have the optimum study from the French group showing that using lower doses based on avoiding high blood levels as it significantly reduces the levels of pleural effusions while maintaining just as good molecular responses. Then you have the MD Anderson study, which is now fairly mature, 3 or 4 years follow-up, where their molecular responses are better than their historical responses with 100 milligrams of dasatinib. And then we have our own study in Australia where we've used blood levels to dose reduce along the lines of the STIM study, where nearly everybody ends up on 50 milligrams after 3 months. And the results in that study are as good as any other frontline study we've done. So it seems to be the case that, I think if you use 50 milligrams to start with, you need to look very closely at the 3-month response. And if they're not below 10%, I'd recommend you go to 100 milligrams. But otherwise, I think that for most patients, it can do very nicely. That the tolerance is very good. The rates of pleural effusion is not 0, but it's certainly not 25% like we see in overall with the 100 milligrams. It might be still high in older patients, and maybe there's an even lower dose. I don't know, but I think that's a lot of interest in that. Now, in terms of the other drugs, we don't have the same sort of data for nilotinib. I mean, a lot of us are doing what Jeff was suggesting and lowering the dose once patients achieve a deep response to sort of, because we believe it's safer, but we don't probably have any data to support that, although it seems likely. Imatinib, a lot of us would modify dose, particularly in old, frail patients who are struggling with 400 milligrams. You can go to 300. I don't like going below that. And sometimes I think maybe the patient would be better off on a half dose of dasatinib than on an inadequate dose of imatinib. But that's where it's done. Bosutinib, I have no experience. Jeff probably has much more experience because we don't have bosutinib in Australia. Ponatinib, obviously, we have the OPTIC study, which really demonstrates that once you achieve your response, on 45 milligrams or sometimes on 30 milligrams, you can safely go to 15 milligrams in most patients to maintain that response. You sometimes lose it, but for the majority of patients, that's a very good strategy. And that does reduce the rate of cardiovascular events. Still a problem, but a much less of a problem using 45 continuously.
I think in follow-up, I can talk about bosutinib. I think the best evidence is there for a ramping up in dose. One of the biggest issues that occurred when the first studies were done with bosutinib was at 500 milligrams, boom, you started it. And that killed the first randomized study in terms of double. Then there was a second one that was done at 400 milligrams. But again, the side effects of starting at a full dose aren't significant enough that it does take some people off the drug. I think many of us who use bosutinib regularly have learned about what we call the ramping up phenomenon. And that is, you will start on a dose of 100 a day for a few days, 200 a day, 300. It profoundly reduces the gastrointestinal and the liver toxicity with the drug. And in fact, it's very often find out that you don't even have to go up to doses of 400 or 500. You get wonderful responses at 300, which subsequent has also shown much what Tim has just discussed, what I mentioned before, is you can come down on doses of a number of these drugs if you have a good response. So I think bosutinib is the class example where if you want to avoid those side effects like the diarrhea that everybody's spraying up, ramp it up slowly. And the majority of people do not get that side effect. So I think that is the classic example for starting at a lower dose.
Okay, great. Thank you so much for sharing. There's one follow-up question. We've already touched this a little bit, asking from your clinical practice, do you reduce the dose upon reaching a certain milestone? Do you regularly reduce the dose?
Why don't I start?
And if so, which milestone?
Ponatinib has been shown with the OPTIC study that once you get your 1% SI level, 2 log reduction, equivalent to roughly a complete cytopenic response, you can reduce down to 15. And as Tim mentioned in a little more detail, the responses in the majority of people are sustained. What I'm finding is, again, with nilotinib, I'm coming down on the dose of those individuals because of my concerns about the long-term toxicity. So I do reduce. My target for usually reducing the dose is at least MMR or a 3 log reduction that is sustained, or hitting 4 or 4.5, I will. And in all honesty, I have reduced nilotinib, I've reduced bosutinib, I've reduced imatinib. I think it is possible. I think the key is you cannot do it without monitoring these individuals. You have to be careful. there was at least one study, an English study, which actually looked at a dose reduction before cessation, before a TFR, and they did find some individuals, when they have the dose of, I think it was imatinib, did start to lose response even before they stopped treatment. So it does occur. I have not seen it, in all honesty, and I've now done this with, at least 50 different patients, but I monitor them a little more closely during that period of time. And the moment I see a move in the wrong direction, I go back up.
Yeah, that's critical. Yeah.
Great. Another question to you, Tim, this time. Do you think that reducing the dose before reaching a deep molecular response would or could jeopardize reaching a subsequent deep molecular response?
Yeah, that's what we don't know about. I mean, certainly if a patient is achieving a deep response and they're tolerating their drug well, and it looks like in a year or two they're going to be eligible for treatment-free remission, I mean, my preference is to push on, but we have that debate. I say to them, look, we could reduce your dose if you think that fatigue you're having is going to be a bit better. Maybe it will be on a lower dose of whatever you're on. Then you can do that. It may not have much impact on your eligibility for treatment-free remission, but it might. So I guess being someone and being at a center that's very focused on maximizing treatment-free remission, I probably would be more on the side of maintaining that dose. As long as I wasn't worried about the safety issues, I wouldn't be very keen on maintaining nilotinib over a very long period, as I've already mentioned. But that's the potential downside of lowering the dose, that you might not have the same success rate when you stop, but I don't have any evidence either way on that because no one's done the study.
I think Tim brings up an easy point, which is one of the other questions that someone sent in, is TFR. I think roughly, about half the people who go on any kind of TKI seem to be eligible for TFR. And then in the vast majority of the TFR studies, and the studies are only with imatinib, bosutinib, and nilotinib, although I think bosutinib would probably be the same given its mode of behavior, I think only about half the people successfully have TFR, roughly. There's some, I've just seen some MD Anderson data that shows if you go 5 years or more with a deep molecular remission, they have an 80% success rate in TFR. But I think that is the exception rather than the rule. So I think the bottom line is the majority of your patients are not going to achieve successful TFR. The majority.
See, that's where we differ, Jeff.
Pardon?
That's where we differ. I think we can get the majority of our patients to TFR. I mean, I think you're right in terms of the 5 to 8 year data, but we're now looking at 15-year data where patients eventually do become eligible. And a lot of them will have a second attempt, and a lot of them will succeed with a second attempt. I mean, our figure at the moment for successful TFR at about 14 years is 40%. And I think, by 18 years, it'll be 50 or 60%. So I'm not quite as,
but that's
I'm not saying you're negative, but you're.
Of people who are eligible, or people who.
No, of my whole cohort of patients, the cumulative incidence of achieving treatment-free remission by 14, 15 years is around 40%. That means there's another 30% or so who are eligible but can't get there, and maybe we need other strategies. But I have a very proactive, attitude to treatment-free remission. I think we should be pushing for it, but not to the point of leading to misery and toxicity, but just focusing on it and trying to do whatever we can to get there. And that's where, clinical trials and lots of other studies need to be focusing on it. So that's where I think we differ. It's probably the one area we differ the most.
Well, maybe I was thinking within the timeline of most of the studies. So maybe if you go out 14, 15 years, which the majority of people on the studies were not.
Yeah.
I think so. I will concede that's a possibility. I think there still will be a significant number of your patients who are not going to be able to stop.
Yeah, no question.
With
current technology.
The long-term toxicities.
Yeah, with current treatments and current understanding.
We are eligible for, quotes, a lower maintenance dose. I don't like the term maintenance, but a lower maintenance dose of drug because they just simply are not successful.
There's certainly outpatients. There certainly
Tim
are
and
patients that are more interested in going to a lower dose and not rocking the boat than leaping into the treatment-free remission experiment that they would regard it as. And that's fine. I don't want to make them feel guilty about it, but I guess I think we can get a majority of patients over the next decade into treatment-free remission. I hope so, and I think it's possible.
Well, those are the patients I find the most difficult to stop. You know, in the old days, we used to harp on patients about missing doses and what might happen if they missed
that's right.
response. And then I suddenly turn around and says, "You beat my head because I missed 2 doses last month, and now you're telling me to stop."
Stop.
And really, we're now introducing the concept of treatment-free remission to patients over the last decade, 15 years or so.
Yeah.
But you've got patients going back even further. What?
You said I couldn't stop. You said
they're the ones I can't get to consider it.
Yeah, I say to them now, you have to take it every day now, so that maybe in the future sometime you may not need to take it at all. And that's kind of a good motivating thing for them.
Yeah, you're right.
Jeff, Tim, that's a very interesting discussion. And this reminds us that it's definitely time to schedule another iCMLf conversation on treatment-free remission. There's so much to discuss.
Absolutely.
It's really worth. That's a great reminder. If you don't mind, I'd like to jump in with another question on dosing and toxicities, which is related to ponatinib. There was one question on rash, drug rash, related to ponatinib. And in addition to asking what should be the optimum dose of ponatinib in patients with blast crisis who experience drug rash.
Patients with what?
Blast crisis?
Rash.
Sorry, blast crisis or rash or both?
Yeah.
I didn't hear either.
Rash related to ponatinib. Okay. That was a question. Sorry for pronouncing.
So I think the whole concept of rash for TKIs, all TKIs give you a rash. It may be a very different effect. Up to 10% of imatinib patients get a rash in the first few weeks. That very interestingly, if you hold the drug till the rash clears and restart it, the rash doesn't come back from the drug. And a lot of the patients may continually have this punctate, slightly raised rash that you see in some of those. I guess the question with ponatinib is, what dose do you need? If you've got a T315I mutation, you've got to go with 45 until you've got a response. You can lower the dose because there are people even on the OPTIC study who got responses on 15. The first thing you need to determine is the rash due to the drug? So you may even require the same strategies with imatinib. Hold it for a few days or a week or so, see if the rash goes away and re-challenge. Then the decision is, if the rash comes back and it is a debilitating or quality of life affecting rash, then I have to think you need to make a decision. Are there other drugs available that can do the same thing for what you've got other than ponatinib? Because if it's affecting quality of life or symptoms or things like that, you may have to switch. But I think we all are heading with ponatinib because of toxicities. Once you get response down to 15, I think that's but you still can get responses, as the OPTIC study showed, at 30 milligrams a day and at 15 a day. Not quite as fast, but you can.
Any other opinion from?
Yeah, I just think, and leaving aside the rash for a sec, but in terms of the dosing of ponatinib, I mean, the OPTIC study is a beautiful study, and it gives us great guidance about, the potential advantage of using the higher dose to start with, compared to using the moderate dose or using the low dose, but also the additional toxicity of doing that. I think it's very clear cut that the patients with T315I or patients with highly resistant disease significantly better off having the 45 milligrams. And so that's what you tend to do unless they had really, really worrying cardiovascular features. But for the patients who have mid-level resistance or no mutations, the advantage is kind of not that much. And in that case, you might want to just think about the relative risk of cardiovascular episodes. And so some patients you might choose 30 and reduce to 15 when you achieve a response. So it's really, it's quite complex because you've got to factor in all of those, the cardiovascular risk, the nature of the resistance before you decide what's the best dose.
Okay, great. We are running a little bit out of time. So it's already we had 45 minutes. I think there's time for 1 or 2 final questions. I'm just checking the chat. There were a couple of more questions coming in. So 1 or 2 more questions. Does imatinib cause elevated thrombocytosis?
That's an interesting question. I mean, I think if you see thrombocytosis in a patient on imatinib, I'm assuming they haven't got hematological relapse, because that would be a cause for thrombocytosis. Let's say a patient's got a MMR and they have thrombocytosis. We do see these, not uncommonly, these patients who have essential thrombocythemia as well as CML, and it's not in the CML clone, it's a separate clone. And that's not, I mean, it's not common, but it's not uncommon. So always think about that. And that can happen even in patients in TFR. Sometimes you see the hemoglobin start to creep up and you do a JAK screen and they're actually PRV. So be aware of that. It's probably a higher incidence. I think we've all seen that in our practice. It's, you don't just ignore it. I mean, it could also be iron deficiency, of course, or other causes, but keep in mind that it's there seems to be a higher incidence of MPN in patients with CML.
I think we're recognizing that a lot more. Remember, at the presentation of CML, I've seen people present with 1 million platelets and a white count of 15, and they've got CML. So CML is typically not always present with a high white count, and so it could be that at diagnosis. Agree, rule out iron deficiency. It's very common, but I've now got half a dozen patients who have essential thrombocytosis or myelofibrosis. I've got patients who are undetectable with a PCR sensitive to 5 logs or more for BCR-ABL and have a spleen into their pelvis. And they're patients where you find have 2 diseases. They've got JAK2 or CALR positive myelofibrosis or essential thrombocytosis, just like Kim said. And I think you have to look for it. And there's actually some of these patients I've gone on to transplant for the myelofibrosis, not for the CML.
Yeah.
Okay. I think we need to come to an end right now. Before we end, question to you, Tim and Jeff, are there any important topics, anything we haven't touched that seems to be important of you, just as closing the session?
No end of things we haven't touched about that are important. This is just like scratching the surface, but I think there's been some good questions and good discussions. So that's been useful and enjoyable.
It's been fun, and I'm always glad to interact with Tim. I think the most important thing is you always have questions. You know, I have questions. Tim has questions. We bounce questions about the internet is wonderful. As I've never seen this before. Have you seen it? And you can get an answer from some of your colleagues around the world. And I think the important thing is if there's something you have a question, there's so many people out there who are approachable and can answer your question, or maybe they'll tell you there's no answer. Don't feel restricted. You may be able to get on the internet or something and calling one of your colleagues in your own country or closer to home. Most people will answer. So
we get a lot of questions like that.
It's an amazing resource that we have, and I think all of us at whatever level we are all use it.
And
don't forget we have our iCMLf forum, which has a lot of those great cases, and Jeff's been one of the best answerer to all those difficult questions. So keep them coming.
Absolutely, it's always open 24 hours. So please submit any additional questions or interesting cases. It's all about discussing interesting cases. And there was one additional comment on the chat. I don't know if you have seen it. We've been discussing like studies or evidence related to toxicities in pediatric CML. And we'd like to point out that there is a very, very recent module on our Knowledge Center. So please feel free to visit. And there's a specific module or presentation on managing practicalities.
It's a good module.
So checking. So coming to an end, it's time to say a big thank you to you both for chairing or co-chairing this session, and especially for sharing your expertise from your clinical practice. And it's time to say thank you to all of you for submitting your questions either prior to the meeting or live during the chat. And it's a pity, it's all the time. We don't have enough time. There's so many interesting questions, but we definitely have our next iCMLf conversation soon. We have the case discussion forum. So let's keep in touch. Any additional questions, please feel free to email us as well. And our next formal iCMLf conversation will be in July with highlights from the EHA meetings. Experts and timing will be confirmed soon, so please watch out on our website and on social media channels to get the confirmed date. Thank you so much, and have a lovely rest of your morning, evening, wherever you are in the world. Thank you so much.